Hello and welcome to our CLC presentation for Principles of Corrective Exercise. I'm Giovanna Hernandez and I will be introducing the first part of the CLC. You will also hear from Isabella, Gavin, and Alexia throughout this presentation. To start off, our client is a 25-year-old female that is 5'6" and 160 pounds. She started working at the Amazon warehouse where she packages items into boxes, lifts boxes, and uses machinery while performing her tasks. She also continues to be active by incorporating strength training and does long-distance running. She also did play varsity basketball her 4 years in high school. She also forewent a meniscus tear in her right knee in her high school career, as well as have patellar tendonitis in both knees. She always had pes planus or been flat-footed. She has tried using inserts in her shoes to correct and maintain the arch in her foot. However, she had a hard time remembering when to keep them in with all the shoes she has. The PAR-Q is a 7-step questionnaire that is utilized for individuals of all ages. According to the American Physical Therapy Association, it determines the risk factors during moderate physical activity as well as help review any family history and diseases the client might have or the seriousness of them. As we can see, our client checked no on all of these 7 questions. This means she can move in doing physical activity and gives no reason for any other risk. Before analyzing the static posture, you can see there are going to be lines in the pictures you will see in the next slide, going horizontally and vertically in the pictures. This is called a plumb line. These lines help identify any deviation or asymmetries in the individual's posture. With these lines, it is important to note that they need to be drawn appropriately to be useful. The client needs to be wearing form-fitted clothes to better assess them. Remind the client to use their natural posture, as they will be self-conscious and want to correct their posture while you are making the assessment. Remember, when you're looking at these views, we can start from the feet and go up the kinetic chain. So this would be the feet, up to the knees, up to the lumbopelvic hip complex, to the shoulders, and to the head. From the anterior view here, we can see starting at the feet and the ankle. Both feet are flattened, but they are pointing straight and they're not externally rotating. However, we can see this left foot right here has a little bit more of that overpronation occurring. Moving on up to the knees, the left knee looks like it's slightly off of the line, lining up with the toes, making the knee want to adduct into valgus. Going up to the lumbopelvic hip complex, the pelvis is level with both posterior superior iliac spines. The shoulder is slightly drooping on this left side, whereas this right side is slightly elevated, making it look like it's uneven. However, the head is in a neutral position, not causing any rotation or tilt in this anterior view. From the posterior view, the left heel right here is pointing straight forward, while the right here is overpronating, showing that the arch has fallen onto the floor. This is causing the knee to either go into knee valgus. However, we can't really identify or see that there's knee valgus, but we can definitely see that pronation of the foot right here. Going on to the hips, the pelvis is leveled with both posterior superior iliac spines. However, there is a slight deviation or malalignment in this posterior view when we look at the shoulders. The left, it looks like it's drooping down, and this right shoulder is slightly elevated and makes it look like we're a little bit crooked. But as we go up to the head seems to be in a neutral position, not rotating or tilting. From the last view right here of the feet, we can see that the feet look like they're in a neutral position. The knees are not hyperextended nor showing any sort of flexion in the knee. However, we can definitely see in the lumbopelvic hip complex, the pelvis is anteriorly tilting forward, causing lordosis in the back. However, we can see that there is a slight rounding of the shoulders right here, and this could probably be a result of the lordosis and the lumbar extension that is occurring in the pelvis right here. But after that, we can see that the head is not protruding forward, and it looks like it is in a neutral position. So with everything that I had stated, this is some of the normal and abnormal abnormalities that were ongoing into all those views. So from the anterior side, this would be from the feet, the knees, the lumbopelvic hip complex, the shoulders, and the head for all anterior, posterior, and lateral views. They all summarize of what I just said. For example, the feet, the straight and parallel feet were pointing forward and they were externally rotating. However, the abnormality would be the pronated feet in the PowerPoint or in the picture that you had seen. Because of all these abnormalities or deviations that we can see in all these views, there will be overactive and underactive muscles. So for the foot pronation, the soleus, the gastroc, the peroneals, the IT band, the adductor complex, the TFL, and the hamstrings will be overactive in that foot pronation, whereas knee valgus will occur because the adductor complex is overworked, is an overworked muscle. Whereas the lumbopelvic hip complex, where we saw that unleveled hip height essentially in the static posture, where that occurred, the biceps femoris, the adductor complex, the piriformis, the gluteus medius will be the overactive muscles. The anterior pelvic tilt, the TFL, the psoas major, the rectus spinae, and the rectus femoris will be overactive. Some of the elevated shoulders would include some of the overactive muscles of the levitator scapulae, the upper trapezius, the rhomboids, the subscapularis, and in some of the forward head movement, which I didn't have any of those forward head movements in any of the pictures, the sternocleidomastoid would be the overactive muscle. Whereas in the underactive muscles, foot pronation, it could be the anterior and the posterior tibialis, the gluteus medius, and the maximus. The knee valgus can have an underactive muscle of the gluteus medius. The unlevel lumbopelvic hip complex would be the adductor complex and the anterior tibialis. And the anterior pelvic tilt can be occurring from the underactive hamstrings, rectus abdominis, and the gluteals. Elevated shoulders can be occurring because of serratus anterior muscles, latissimus dorsi, the infraspinatus, pectoralis major, and minor underactive muscles, and the forehead head movement can occur because of weak, deep cervical flexures causing that head forward protrusion.
Alrighty, well, hello, my name is Gavin, and today we're going to be talking about the transitional movement assessment. And the two that we're going to be covering in this PowerPoint is going to be the overhead squat and the single leg squat. we're going to be talking about the compensations that you want to be looking for with clients, the compensations that you will observe throughout my demonstration of my movement, and then the possible overactive and underactive muscles that may be causing this compensation. So first off, let's go over the overhead squat. So starts off, the compensation that you will observe within my movement is going to be the arms falling forward. So let's go ahead and watch my demonstration real quick. So it's difficult to see the arms falling forward with the anterior view because you can't see the arms falling forward. So that is the anterior view. Just wanted to show you guys that. But with the lateral view, you can clearly see, especially with the angle with my torso and my shoulders and my arms, that angle becomes a little bit smaller once I hit that 90-degree, or where my femur becomes parallel with the ground. You can see the falling of the arms. So other than the falling of the arms, other compensations that you want to look for when assessing clients are foot flattening, knee valgus, that one's very common, rounding in the lower back, arching in the lower back, your heels rising, asymmetrical weight shift, knees moving outward, and excessive forward lean. And as I mentioned previously, the observed compensation with my movement is the arms falling forward. So possible overactive and underactive muscles that are causing my arms to fall forward or this compensation would be the lats, the pec minor, the pec major, the coracobrachialis, and the teres minor. In my scenario, I would predict that the tight muscles, the lat, because it's pulling down my arm back to that shoulder extension back into that natural resting position, making it difficult to keep it up while I'm moving down. And then the possible underactive muscles would be the mid to lower trapezius, the rhomboid, the posterior delts, and the rotator cuff. So it's very easy to see the compensation within the two pictures I have here at the bottom. So you can see the angle that I have here with my shoulder, my arm, and my torso in comparison to when I'm here at my 90-degree angle. You can see a little bit of a change in angle, decrease in the angle, meaning that I'm having that drop with my arms more than I should. Within a squat, our chest does drop naturally, meaning there is going to be somewhat of your arms falling. That's why it makes it helpful to look at this angle here with the shoulder, so it's easier to see rather than just looking at like, oh, my arms start here and going down. You're able to see an angle and an actual measurement for the falling of the arms. So that's the overhead squat. Onto the single leg squat. So let's show you guys this video. For this one, we're looking at my right and left knee valgus. So you can see it's actually for both knees, pretty much with every single rep, you'll see my knee internally rotate. There it is with the right leg, pretty much for every single rep. And then here again with the left leg, internal rotation, internal rotation. So other compensations to look for, again, when assessing a client other than a knee valgus would be hip hiking, hip dropping, inward trunk rotation, and outward hip rotation. And again, as I mentioned, the observed compensation through my demonstration of my videos is the knee valgus in the right and the left knee. And the reasoning for this compensation would be a possibly overactive adductor complex that is as it's pulling your knee inward. The biceps femoris, the TFL because it's an internal rotator, the lateral gastroc as that's causing ankle hyperpronation, and the vastus lateralis as well. And then in addition, possible underactive muscles could be the medial hamstring, the medial gastroc, especially here the glute med and max, because the glute med is going to be that hip adductor, which could pull that knee back outward, fixing its position. And finally, the vastus medialis. So you can see again here in these two bottom pictures, the knee here at the beginning, very straight. As I come downward, clear knee inward rotation. You can see a clear knee valgus.
Hi guys, so today I'm going to be talking about the dynamic postural assessment. For this we did the gait analysis, so I have the posterior and lateral view of myself. For the activity, it asked me a bunch of questions, so I'm just going to go over that in the PowerPoint as well. So the first question it asked for the gait analysis was, do my feet turn out? If you look in the posterior view, you can see some turning out of the feet, And then also it's a little bit harder to see on the lateral view, but I said yes for that. For feet flattening, I said no. I saw some arching when looking at the posterior view and also the lateral view. You can kind of tell here and then also here. Do the knees move inward? For this, I said no. I didn't notice anything major in both of the views, so I'm going to go with no for that one. Does the lower back arch? I know that my lower back arches, and I can kind of see it in the posterior view. In the lateral view, it's a little bit harder to see, but I still said yes for that one. And then also, does the pelvis rotate? I also said yes on this. You can kind of see it a little bit in the posterior view and the lateral view as well. For the hips, it says, do the hips hike? I said no. I didn't see any major hiking of either my right or left hip. Do the shoulders round? I said yes. You can kind of see it in the lateral view, and then in the posterior view, you can completely see a hunch of the shoulders. So I said yes for that. And then for the head migrating forward, I said no. In the lateral view, you can see a pretty straight line here, and then also in the posterior view. So to go over those a little bit more for the potential overactive and underactive muscles, starting with the overactive muscles, for the feet turning out, I said the piriformis, the soleus, and the gastrocnemius. And then for the feet turning out underactive muscles, I said the external rotators of the hip, your tibialis posterior, calf muscles, so that includes your gastrocnemius and your soleus. Lower back arch, so your anterior pelvic tilt, overactive muscles. I said the erector spinae, your tensor fasciae latae, also known as your TFL, the rectus femoris, and then your iliopsoas. For the underactive muscles for the lower back arch, anterior pelvic tilt, I said the abdominals, so your rectus abdominis and then your transverse abdominis. And then also your glute max and your multifidus. For pelvic rotation, overactive muscles, I said the adductors, your external obliques, and your quadratus lumborum. For the underactive muscles for the pelvic rotation, I stated the gluteus maximus and medius, your rectus abdominis, and your transverse abdominis. And I got all this information from our textbook.
Hi, my name is Alexia. I'll be presenting the LESS test, also known as the Landing Error Scoring System test. For the first slide, there are the 4 different stages that are part of the LESS test. So you'll have start, jump, land, jump. And then on to the next slide, you'll see the normal findings for the LESS test. So knees over midfoot during initial contact, ankle plantar flexion, initial contact, foot symmetry, stance shoulder width apart, hips flexed, trunk flexion, knee flexion greater than 45, and then knee valgus displacement. Anything that would be the opposite of any of the normal findings are obviously going to be abnormal. So a very common abnormal finding would be knee valgus. So knees moving inward. Also like foot symmetry, one foot in front of the other when starting. And then your overactive muscles for the LESS test. To start out, if the feet were turned out, your overactive muscles are going to be the lateral gastrocnemius and soleus, and then relating to underactive for that same category, it's going to be medial gastroc and glute max, and then feet flattening is another dysfunctionality that we see. Your overactive muscles are going to be lateral gastrocnemius again, and then TFL. Underactive is going to be anterior and posterior tibialis. And then knee valgus, the overactive muscles are going to be the adductor complex, so adductor brevis and longus, and then as well as biceps femoris, the short head. And then your underactive muscles are going to be anterior tibialis and posterior tibialis. Excessive forward lean, especially during the squat and jumping stage of the LESS test. Your overactive muscles are going to be hip flexor complex and then piriformis. Your underactive muscles are going to be the erector spinae and transverse abdominis. And then that concludes the LESS test.